Okay. All right. Okay. Hi, everyone. My name is Gwen Driscoll. I am the Director of Communications here at the UCLA Center for Health Policy Research. Thank you for joining us today for a glimpse of some of the first data coming out of a national effort to improve public hospitals. So it should be really interesting. But first, a note about next month's seminar. Federally qualified health centers, commonly referred to as community health centers, serve as critical safety net providers to those who are uninsured or who may become uninsured. In this July 31st seminar, Center Associate Director Stephen Wallace and graduate student researcher Maria Elena Young will discuss findings from a new study, upcoming study, on these centers' efforts to serve the remaining uninsured. Specifically, Steve and Maria Elena will examine strategies undertaken by CHCs in 4 states that reinforce the local safety net through partnerships, improvements to the local health system, and advocacy. With the uncertainties ahead about whether the Medicaid expansion will be continued or be handed over to the states, or who knows what's going to happen, the partnerships, both among CHCs and with others in the healthcare system and beyond, may become even more important. So please join us for this, unfortunately, more relevant than ever topic. Again, that's July 31st at noon. Oops. There it is. Okay. As for today, we will be recording our seminar, and it will be placed on our website at the address you see at the top of this slide. If you're watching online and you would like copies of today's slides, please email me, gdriscoll@ucla.edu. Please also note we will have a brief question and answer period at the end of the seminar that I will moderate. Now, on to today's seminar. California has 12 county hospital systems and 5 University of California public hospitals that deliver the majority of inpatient and a significant amount of outpatient care to Medicaid patients in the state. The center was selected by the California Department of Healthcare Services and partially funded by the Blue Shield of California Foundation to evaluate a wide-ranging effort to promote innovation and to improve care at these hospitals. The program was called the Delivery System Reform Incentive Payment Program, or, as we finally call it, DSRIP. It should be noted that at least 13 other states are implementing DSRIP or a DSRIP-like initiative, but California was first out of the gate, making these findings significant to the broader national experiment in health system reform. How big was DSRIP? Well, it was a 5-year project with a $3.3 billion budget. The hospitals that participated collectively served more than 2 million patients annually. But the biggest thing about DSRIP was perhaps the idea at its core: pay for performance. The program incentivized participating hospitals to test cutting-edge strategies to improve care by rewarding them if they met designated milestones. And meet those milestones they did. Nadi will talk more about this. Participating designated public hospitals achieved 3,643 out of 3,764 milestones established to measure their progress. And they did this through a wide variety of programs. Dr. Nadereh Pourat, who leads the center's Health Economics and Evaluation Research Program, was the lead evaluator of the California DSRIP program and recently completed a massive report on the effort, as well as a shorter summary policy brief published today and available on the center's website, www.healthpolicy.ucla.edu. You can see our website address at the bottom of this slide. In today's seminar, she will discuss the broad scope of the DSRIP experiment, what interventions were the most successful, and what DSRIP means for hospital reform in California and the nation. So please welcome Dr. Nadereh Pourat.
Thank you, Gwen, for the introduction. So we'll jump right into materials, if I can figure out how to navigate. Okay, so as Gwen just described, DSRIP was a national effort 9 states have implemented DSRIP programs. California and a second one, I believe at least, are in the second phase and doing a continuation with some modifications. And there are other states that have also done these kind of programs. The mechanism under which DSRIP has been implemented is called a Section 1115 Medicaid waiver. This is an opportunity for the states to experiment with how the program is being implemented. And the primary goal is to sort of do innovative things to improve program efficiency. In contrast to California, actually I'll go back, just to give an idea of how different these programs are across the country, Texas, for example, implemented a program that focused on the hospitals, but it also brought in a series of different types of providers, such as community health centers. So they tried to implement these projects and improve care efficiencies in that way, as opposed to New York, which actually has tried to develop these integrated delivery systems. So it's a very involved and very complex project in what's going on. In contrast to some of these efforts, California's DSRIP was actually a perhaps smaller scope, if you could describe it that way, because it's just focused on improving healthcare delivery in the public hospitals in the state. There were 21 designated public hospitals, and the term designated refers to the fact that 5 of those are actually not county-owned and operated public hospitals, but they are UC, University of California hospitals. So those are the 5 academic health centers. The remaining are public systems. And 6 of these actually had more than one hospital. They were multi-hospital systems. For example, LA County, 4 hospitals were participating under that particular umbrella. The time frame for the demonstration is identified 2010 through 2015, and there were biannual incentive payments, and I'll describe those a little bit more as we go forward. A little bit about how this program's actually put together, because it was not very, it is rather complex. So there were categories, there were projects within categories. Within the projects, there were elements that you could select. Within the elements, there were milestones that you had to choose, and then the metrics, which pretty much corresponded to the milestones. So we'll go through those really quickly. Categories were essentially these following 5 categories of projects. A strong focus on developing infrastructure, then changing how healthcare is being actually delivered, and that's the redesign of the care delivery system. Improving care delivery for complex patients. These were a series of measures that the hospitals had to establish and report on. And then improving care delivery in the inpatient setting. These were projects designed to reduce adverse outcomes in the hospital setting. And then there were a series of projects that just focused on the HIV patients. And this one was not implemented by all the hospitals. Only 10 of the hospitals participated in this. There was a different application process for Category 5. So it was essentially a whole different projects for the hospitals that were interested in implementing it. So within the projects, for example, in Category 1, there was a maximum of 12 projects that you could select from. You had to choose 2, but it was not identified as which ones. You had freedom in choosing the ones that you wanted. Category 2 was pretty much similar, and Category 3 were 16 measures. Everybody had to report on those. Category 5 was a total of 7 projects that you could select from and 10 performance measures. So I'll just provide a couple of examples on Category 2 projects just to provide a little bit of depth. And that, for example, you can see establishing expanding medical home was one of these projects. And within that, you could choose to restructure staffing into multidisciplinary care teams, or you could empanel patients, you could manage medical home panels actively, etc. These are examples of the projects that you could implement, or elements within those projects that you could implement. And then the milestones, which were sort of actual measurements that that you could do. There were a total of 10 measures that were called process measures, because these are things you had to do. And then there were those improvement measures where you actually had to show improvement, a change. And in this case, for example, tracking the assignment of the patients, you essentially, it's a yes, no, whether you were tracking the patients. And then an example of an improvement project is when you actually had to show how many people were assigned. And the metrics correspond directly to the milestones, so it's kind of clear. Some are numeric and some are essentially completion of a task. Gwen mentioned the over 3 billion in the funding. That was the amount of money that came from the federal government. So the DSRIP program, similar to the Medicaid program, is a match. Some of the money is coming from the state, the rest of the money comes from the federal government, and there is a proportion how this is distributed. The total funding for the program was $6.67 billion. It is smaller than Texas and New York, but it is bigger than some of the other states that participated. This just provides a little bit of a glimpse of exactly how those funds were distributed. There was, as you can see, the amount of money that was distributed was much greater to begin with, and that's because hospitals had to develop the infrastructure and do that kind of work. And then over time, the amount of money was reduced because then you just had the projects settled and you were working on developing, improving the outcomes. They were adjusted by the size of the hospitals and some of the things that were unique to the hospitals. So the hospitals were quite varied in their size and their scope. The method was essentially a bundled payment per project. So you could do several different projects, but the payment was per bundle for that particular project. And there was an achievement value, how much of what you had set out to do you were able to achieve, and that's how you will get paid. The disbursement was biannually. Half of the allocation came in the first half of the year, and the second will come in the second half of the year. The evaluation framework, as you can see, sort of models after the categories. So we will look at the impact of each category. To the degree possible, we try to also look at the relationship between these. And that was a little bit challenging because we did not necessarily have data in all the cases where you could do those kind of analysis. And I'll explain that a little bit later. The overall goal of the DSRIP was the triple aims of better care, better health, and lower costs. So this was the overarching effort was supposed to achieve these kinds of goals. The data sources, as I mentioned, were quite a bit of qualitative data. We used the annual and semi-annual reports that the hospitals produced. They had to report a lot of metrics, and we used those metrics and based a lot of the analysis on those metrics. We conducted surveys, and when I say survey, it was a fully structured questionnaire. We don't have that many hospitals in the sample, only 17, but we asked systematic questions from everyone, and we followed it with structured interviews just to get a little bit better depth in what it is that they were doing and how they achieved their goals. We used two other data sources that were available to us. The California hospital discharge data we used for Category 4 to independently assess the impact of the program. And then also the low-income health program data, which was another one of the waiver programs where we actually had patient-level information, and we used that information to assess the impact of that category. The survey and interview themes, of course, sort of were the following points. We wanted to understand what were the synergies with the other projects that the hospitals were implementing, what were the organizational goals, what they were trying to achieve. We looked at what their implementation challenges and solutions were, what was their perceived impact. And this was particularly important because we were not able to independently always assess impact. So we did not have data across all of the hospitals on the broader impact of the program. We were very interested in sustainability of these projects and also what the hospitals say about the overall impact on the organization. This beautiful graph, in my opinion, shows you some of the, how the hospitals choose the projects that they were participating in. Category 1 and 2, if you recall, were all optional projects. So you can see that the hospitals definitely were focusing on specific projects. And the way you see that is these really, the biggest circles. As you can see, this is category 1 are the dark blue circles. Category 2 are the lighter blue circles. And those, the strength of the selection, if I can say it that way, it shows by the dark lines between the projects. So you could see that most hospitals, this is 11 out of the total 17 systems, chose implementing a disease registry. They also chose expanding capacity for primary care within the hospital. And then they were also very interested in implementing medical home projects. And sort of, if you're sort of following what's going on in the world of primary care, you can see that these are all interconnected. Having a disease registry, having more capacity for primary care, and also expanding the medical home or implementing those projects are all the kind of efforts that are really promoted and are taken on by a lot of different providers. Moving on to the reasons for selection of these projects, most of the hospitals told us, this is based on a lot of different projects, and we're reporting on all of them, 91% of the projects that were selected because they were consistent with the hospital or the organization's goals. The second most frequent reason was availability of champions. So you got to select things that actually is consistent with the organization goal, but in order to do it, you need to have people that will take on the cause and move the project forward, and champions are essential in this kind of implementation of these innovations. Synergies with existing projects, if you're already doing some projects, it is perhaps a little bit easier to also do something that's related to that. It ties in again with the consistency with organizational goals. And interestingly, the projects that were, very frequently people said that they chose projects because they were easy, and very infrequently they said that they chose it because it didn't have a lot of requirements for resources. So they didn't necessarily go for easy projects. They didn't go for projects that didn't take much effort. So we asked them about whether they were actually doing these kind of projects before, how much of this was new to them. And what you can see is that for all of the categories, the darker red shows that they were doing something related to these projects. Now, we did ask them about how much that something was, and most of the time they might have been doing a project in a specific department, or they might have been doing something very limited. They were not organization-wide efforts, and the impact of DSRIP on the organization was to expand these system-wide and implement it broadly. Some of them reported that they were planning to do these projects before, but they didn't actually have either the health information technology resources, the capacity and the trained personnel in the organization to do it, or other financial resources that might have prevented them from doing it. And then the group of projects that were not really done as much before were category 3, were these measures, population health measures that hospitals were not collecting. They were doing a lot of category 4 measures. As you might know, that a lot of these adverse outcomes are already being promoted heavily by organizations like CMS. Sometimes there are penalties associated with it. So a lot of hospitals were focusing on those, and few were not doing them, and that's kind of came clearly across. These were just very qualitative questions. How difficult were these projects? And you could see across the board, they all are reporting that these projects had high or very high level of difficulty. These were not kind of projects that were easy. The hospitals needed the additional resources to actually get these things going. Gwen mentioned the fact that a lot of these hospitals actually achieved their milestones. And what's interesting, overall percentage is like 97%. At the time we were collecting the data, which was right close to the end of the project, but after that the hospitals had an opportunity to update their numbers and provide additional information, and of course that went up even higher. I think by the end it was either 98 or 99%, and that was by design. The goal was not to be punitive as much as to make sure the hospitals are actually able to achieve the goals that they were set out to do. The other interesting thing is that the speed at which these milestones were achieved. In year 1 and 2, as I explained, a lot of the effort was going to developing the infrastructure and the capacity to do these projects. And in year 3 is when the reporting of the Category 3 measures happened, as well as the hospitals actually started reporting measures for Category 4. So that's why you see such a steep increase in that year. And then it kind of stays relatively stable until the end of the project. This is a perception of the people that were running these projects at the hospitals. These are the program folks. They were telling us about what are their perceptions of the impact. And rightly, a lot of them are talking about these projects really impact quality of care delivery. They were trying to improve quality and capacity for improving high quality care. So not a big surprise that that's what we heard. And the secondary, of course, if you do improve quality of care, you also are helping to improve outcomes of care. They'd had, in the order by which we were asking the questions, they marked efficiencies as the third most important reason. But so that was one area where we didn't have actual data to see whether the costs went down, and we couldn't do those kind of efficiencies. But we asked the hospitals, what do you base your perceptions on? And they had observed, for example, reductions in mortality, or they had observed some other measures, lower hospitalizations or ED use, emergency department use, and that's what they were basing their perceptions on. These are the Category 3 measures, so we just put some of them up here. We not only looked at the change from year 3, where they had to start to report, but to year 5, which was the end of the project. We also tried to identify the benchmarks. The benchmarks sometimes matched closely, and sometimes they were a little bit different. The denominators were different. They were sort of not exactly the same, but it gives you a big picture idea of how these hospitals were able to achieve their goals. And what's interesting is, for example, when you're looking at tobacco cessation, California hospitals seem to have been, even at the start, they were doing better than the benchmarks. And they showed both the tobacco cessation and child weight screening, they both showed dramatic improvements, as opposed to some of the other benchmarks where they did not necessarily change their ratings from year 3 to year 5. And what I do need to mention is that this particular category was not to be a pay for performance as much as pay for reporting. The goal was to develop the infrastructure in the hospitals to be able to report these types of measures. You'll see later on, of course, these will become pay for performance measures, but it was important that the hospitals had the capacity to do it. And I'm not showing any of the information on this, but the hospitals, some of the hospitals were actually developing their HIT or their EMRs during implementing the project. So sometimes they started using chart review to be able to report these, and by the end of the project, they were actually able to do it electronically. So this was a major challenge. These are category 4, just showing some of the improvements that they had made. There are lots of different measures they were reporting. These are just 3 of them. You can see a decline in mortality from sepsis. You could see a decline in mortality from stroke. This is within a 3-year time period. And you can see an improvement in this preventive measure, which is avoiding blood clots. This was our attempt at trying to see whether we can find a linkage between one category of projects to another. These are category 2 projects, and we were trying to see if the hospitals, we used the category 3 measures to see whether we can see a change. If a hospital implemented a category 2 measure, can we actually see a difference between those that implement and don't implement in the metrics? So what you can see here, for example, is that the hospitals that were implementing projects to improve the expediency of care, timely appointments for patients, actually are showing, that's actually a measure, getting better appointment. If they implemented projects, they had actually better measures like in that regard. So diabetes control, for example, the number of patients with diabetes control went up when people were implementing care transition projects. Sorry, I didn't mention that to begin with. So you could see there is potentially a link between care transition projects. Care transition essentially is talking about people when they are discharged from the hospital. Are they there's follow-up, and there is good transition back to the primary care for those patients. So you could see some definitely changes, better reporting of measures for those hospitals when they implemented those projects. And then category 5 outcomes, this was HIV specific. These were a lot of different things that the hospitals had to report. For example, how much of the patients had a suppression of the viral load. And you could see that in all of the hospitals are reporting improvements, sometimes really dramatic, sometimes less so, but an improvement nevertheless. And it shows you this was an area that improvement was achievable and improvement was necessary. A lot of preventive measures for HIV patients. What were the most sustainable projects? We asked the hospitals. Nobody said that they were just going to discontinue the great majority of the projects. There were 1 or 2 metrics that actually during implementation of DSRIP, the guidance on those metrics changed and they're no longer being implemented, or broadly used in the field. So setting those aside, those unique cases aside, you can see the majority of the hospitals says they are going to either continue the project entirely, and you could see in category 3, we have a very high rate reporting. This is among those that are reporting. So it's not always 17 as the total because some people were not reporting. But people were going to implement. They're going to continue doing that. And the reason for this, of course, is a lot of the hospitals were commenting on the fact that this is where things are going. These are the changes in the field. You have to be able to report if you want to be competitive. If you want to be in the green, you have to change how you do things. And being able to report population health measures allows you to sort of be able to contract for pay for performance efforts or other things that you need to do as an organization. We spent a lot of time looking at what they were reporting themselves and the discussions that we had with the hospitals. What were the challenges? In category 1, there were infrastructure projects, if you recall. They were talking about staffing, being able to recruit, retention, reduce turnover, and training the staff. You train someone, then they leave, and then you have to do it over again. So there were some of these challenges that were highlighted in the discussions we had with the hospitals. Category 2, these were the changing of how you deliver care. And the primary challenges there were competing priorities. You're doing a lot of different projects either together at the same time for lots of different things. So DSRIP by itself, multiple projects being implemented under one project, one program, and imagine all the other potential efforts that's going on in quality improvement. And hospitals had to do these kind of things all together. Then implementing projects can lead to slowing down on your goals in terms of productivity. When providers are busy working on these kind of projects, they are not as engaged perhaps in delivery of care. So you have some of those challenges you have to deal with. I briefly mentioned not having electronic health records, which was also a big challenge. A lot of the hospitals were able to, of course, there was variation in where the hospitals were starting from. Some hospitals started with a lot of capacity, a lot of, they have their advanced in their electronic health records. Some started with very little, and they were trying to catch up during the project. There were switching from, as I mentioned, also switching from doing the data collection in one way and then switching to another form of data collection. Some of them, were talking about having clear instructions on gathering data, and that had to do a lot with the fact that some of these measures changed because the field was changing in the middle. I mean, this is real life implementation of programs, and things like that happen where you suddenly are facing something new while you're trying to implement a project. In category 4, which was the adverse outcomes, there were some very specific challenges. If you already started with very good track record, you're really performing well, and now you have to improve another 2% or 5% or 10%. Is a very different story from some other hospital that might have started at a lower level and they had to achieve 5%. So there's that marginal impact of, if you are really doing well, trying to improve even further is a little bit harder than if you are not doing very well and then you're trying to improve. There were sometimes some of these were very low occurrence problems in the hospitals. So if you don't have a high level of occurrence of, let's say, sepsis mortality, then showing improvement is difficult. And of course, stakeholder engagement, change fatigue, running out of champions because you have already used, your champions are all engaged in doing multiple different things. All of those are the kind of challenges that are part of this whole approach to improving quality of care and improving efficiencies. Our overall impression after looking at all of the data that were available to us was that we felt there was overwhelming evidence of success based on all of the data that we were collecting and all of the analysis that we had done. Hospitals had made progress above and beyond the existing efforts. They were achieving nearly all of the milestones. They were moving towards the triple aims, whether it was perceived or actually realized. There was good evidence of sustainability of these programs. And we felt that the highest contributors to success were synergies with the organizational goals. You have to have the hospital's leadership, the providers, you need buy-in from everybody, and you need everyone to be in agreement that this is where we need to be going. The fact that the hospitals had flexibility in selecting the projects was also very important because they were able to sort of select projects that match their organizational goals and really do things that they felt will move them forward in terms of improving the health of their patients. And then, of course, the infusion of the resources was a very important reason for the success of the program. So, what were the implications of this for the policy implications of this program? I think it was very clear that you need to invest in improving these safety net providers. What I needed to say at the very beginning is that all districts really focusing on the Medicaid program and the safety net. Now, the hospitals obviously just don't see Medicaid population, but they see primarily, a lot of these public hospitals primarily see safety net populations. So they see uninsured Medicaid populations. And because of the volume of patients that needed these kinds of services and the higher demand potentially because some populations, lower income and being uninsured are also highly correlated with high level of need. So it was very important that these hospitals actually got additional resources to be able to do such major projects. I think the findings also show that pay for performance is in fact effective to bring about change in these organizations and do it at a systematic way. And these are organizations that provide care to the low-income and uninsured, as I just mentioned, and that's how you can address disparities. The next step is actually already underway. So California has received a third in the series of Section 1115 Medicaid waiver. And the DSRIP program is being continued with a new name called PRIME, Public Hospital Redesign and Incentives in Medi-Cal. This one will go for another 5 years. It's already in its second year of implementation. It is also bringing in about $3.7 billion in federal incentive payments. It includes more hospitals. Now, instead of the 17 public hospitals, it also includes another 34 municipal and district hospitals. So it's all public hospitals in the state are participating. The level of participation is not the same. It's higher for the public hospital, the first group that had already participated in those projects. They are taking on more projects and they're taking on more sort of a continuation sometimes of the things they've been doing in addition to some very new projects. And the kinds of issues that the PRIME is dealing with is also similar. There are infrastructure development in some new areas, there are process, there are outcomes, and of course a focus on reducing costs. We are evaluating that program as well. And this time we're actually doing a much more intensive evaluation. So I'm going to end there and open it up for, sorry, I'm not going to end it there. I just wanted to make sure that I acknowledge the very, very large group of individuals that participated. This is just the list of people that directly participated, and there was a whole army of additional folks that participated in helping do the evaluation and produce the report. And you can see the report, and I think the link in there needs to be updated, but the entire report is available also online. Thank you.
Okay, thanks, Nadi. The way we do it at these seminars is we take one question from the room, one question from online, and et cetera. And as I already have a question from online, I'm just going to lead with that. In the slide comparing outcomes between hospitals that implemented versus those that didn't, are these significant differences?
Yes. So I don't have to repeat you. Do I? Okay. So yes, there were significant differences. We tried to do a difference in difference analysis, but these are aggregated, reported data from the hospitals. But we were able to see some significant differences, yes. I think what I showed there were just the significant differences.
Nadia, I think, first of all, lots of information. I'm trying to digest it, but when I think of academic health centers and I think of public safety net hospitals, oftentimes I think of very different operations and certainly different patient bases. Did you analyze the results, or were you able to according to those categories?
Yeah, it's in fact very true that public hospitals that the reason it's called designated, because the UC hospitals are designated as a public hospital, but they are not publicly owned and operated like the county hospitals. So they do start in truly at a different place when it comes to some of these things. Their patient populations are somewhat different, but because they're designated public hospitals, they do see many uninsured and Medicaid patients, but not to the same level as, say, LA County would see a much higher proportion. We did some analysis in the report. There's so much analysis, there's just no way I could have shown that. But we definitely did some comparisons by those that were multi-hospital systems versus not. I believe we have some comparisons on academics versus not, but it's just, there are definitely some variations, and I'm sure that you can find it in the report.
All right, some online questions. In comparison to the benchmarks, are those national Medicaid averages?
So if the question is about the benchmarks themselves, we tried to identify benchmarks that were very close, but we weren't always successful. So sometimes there would have been a broader benchmark. There was, obviously we were requested to identify the benchmarks, and we did the best we could, but they were not always exactly comparable.
Nadia, you mentioned that investing in public hospitals and the safety net can help address disparities in access and quality of care. And I was wondering if you were able to look at that in any of your analyses directly, or if you have plans to do so in your sort of ongoing work.
Yes, thank you. Great question. In fact, we were not able to look at those specific things because for a lot of these outcomes, we did not have actual data. So we were using aggregate reporting from the hospitals, and the aggregate reports were not required to be, reported separately by race, ethnicity, for example, or whatever else disparity you would want to look at. However, so for the prime evaluation, our goal is to obtain Medi-Cal data. And Medi-Cal data then allows you to look at subsets of the population. And in fact, those are some of the required metrics that we have to report. So we will be doing definitely racial ethnic analysis to see what the impact has been on those on subpopulations.
Okay, from online, we have a question about incentive payments from P4P go to hospitals. Did actual caregivers receive financial incentives to change behavior? If not, how were they motivated to change their behavior?
So we don't know how the money got distributed. And I don't believe that we actually heard from any of the hospitals whether they were using payment. So the hospitals, a lot of the providers are hospital providers. So I don't know how many of the providers were actually individuals that were getting paid other than the salaried level. And so we don't know really exactly how it got distributed. But there are other mechanisms. You don't always have to use financial incentives to motivate individuals to perform differently. I think that the hospital used, I think we have some data in the report that talks about how they try to motivate the providers by other mechanisms such as showing providers their performance levels. And in fact, some of those non-financial incentives sometimes are just as powerful and might have higher or more lasting effect.
I have a question. Given what's going on in Washington, D.C., will that affect the ongoing iterations of DSRIP, such as crime?
Well, I'm not sure whether it's directly related to that or not. What I don't know is whether Prime is already in operation.
That's funded. There's no chance they can take that back.
Who knows? Who knows? We cannot read the tea leaves, but it's a commitment that the federal government, the CMS, has made to the state. So in order to withdraw that commitment, it's not as simple as saying, well, we're not going to fund it anymore and you're done. I believe that there are certain protections in place that that sort of allows the state to continue. The program's already 2 years underway, and it's got another 3 years to go. So I don't know what might happen. I guess anything is possible. Hopefully not. The question is what's going to happen in the next iteration of these waivers. Whether California will apply for another waiver is a good question. How CMS is going to handle these waivers. The focus of these waivers to date has been, as I said, improve the safety net and improve the health of the population and improve efficiencies. Now, if CMS decides that now they're going to allow different kinds of waivers, such as allowing, playing around with Medicaid benefits, or, it's possible.
Any other questions in the room?
There's one.
So you mentioned that consistency with organizational goals was the main, or came up very frequently as the reason for selecting the projects. I was wondering if by organizational goals, these are more mission type goals or technical, and then if you notice whether there were certain types of projects that seemed to clash with organizational goals more often.
Your first question, in fact, yes, these were consistent with the mission. Where does the hospital and their strategic planning? So they're talking about where they want to go as an organization. What do you need to do in the environment, of course, at the time where DSRIP was happening. So it was that, in fact, because they believed that, for example, as I mentioned in Category 3, they're going to continue all of those. It's not just because they did it and they learned what a wonderful thing it is. It was the fact that they know if you are going to, let's say you want to participate in an ACO, whether it's Medicaid ACO or a Medicare ACO, or you want to contract with a health plan, and they are looking at your performance. They want to know how good your performance is. This is where the field is going. So that's very good motivation to continue these kind of projects. And your second question was whether it clashed. They didn't, if it was an optional project, they didn't select those, right? You just don't select a project that's just not at all on your radar if you can avoid it. If it's some minor thing that you don't believe it's going to help you, it's not going to help your population. There was a lot of sensitivity by the hospitals about these projects have to actually make sense for us. Why do we spend resources on something that we don't think is a need in our community? I think that was really one important reason for success of this program.
From online, did any of the 12 non-UC public hospitals stand out as particularly successful across categories?
I'm sorry that I don't remember. You can look at the reports. We do have, we essentially were not trying to focus on individual hospitals as much as focus on the program. All of the hospitals were doing these annual reports. There's so much information out there. I think our task was to talk about the overall success of the program. Now, it's true that some hospitals would have succeeded much more in specific projects, and then they would have driven the overall programmatic change. But I'd encourage a look through the report because we have appendices that provide some of the measures, especially if they are the numeric measures. And in fact, in the policy brief, if you look, we provided examples of the ones that succeeded. And you can tell whether they are AUC or not.
Okay, well, unless there are any other questions, I'm going to get Nadia out of the hot seat. And thank you very much, Nadia. Very interesting.
Thank you.